Good morning, everyone. Thank you so much for joining me, and thank you to the organizers for having me on the panel in this really interesting time. My name is Megan Anders. I'm an assistant professor and associate chair for safety and quality at the University of Maryland School of Medicine's Department of Anesthesiology here in Baltimore, Maryland, and I look forward to sharing some more information about quality research in anesthesiology with you today. So in a relatively brief period of time this morning, I am planning on sharing some more information about what is quality. I'll review some of the key concepts and definitions. The quality world in general has a ton of unique terms and alphabet soup type acronyms that you probably have not had a lot of exposure to. So I'll give you some of the most important ones. We'll talk a little bit about what makes quality improvement versus research and how to decide which one you're doing. And I'm going to share some of the resources that I think are most important if you are interested in learning more or starting a career in quality research. So what is quality is really the most fundamental thing we need to talk about today. Quality healthcare has been defined as having these different domains, meaning if the research has to do with any of these, it can be considered to be quality research. So we talk about healthcare that is effective, patient-centered, timely, safe, efficient, and equitable. And so to do research on any of those would make you a quality researcher. Careers in quality research, I just want to take a brief detour to explain a little bit about how I got where I am. I obviously am biased. I think this is a great place to start your research career. It really intersects clinical practice with quality improvement and observational research. So I'm going to just take a second to explain how that works out in my career. I'm a practicing anesthesiologist. I work in our general operating rooms. I also did a fellowship in critical care medicine. So I spend about 10 weeks a year working in our surgical intensive care unit. And that really gives me a nice broad view of the patient's experience both in the OR, but also particularly for our highest risk patients, what their post-operative care looks like as well. My quality improvement practice of interest there started when I was a resident. I went and did some physician leadership training in quality improvement, some of the Lean Sigma methods for healthcare. How do you actually get something that seems like a good idea, make sure it is a good idea, involve the right people, and get it to happen? Turns out to have its whole own science and set of methods. So it's important as a quality researcher, I think, that you have some insight into what makes that go. Finally, one of the keys that I'm going to emphasize today is that in quality research, we want to make sure that the techniques we use, the statistics, the study design, are just as high quality as a regular type research project. So we want to make sure that we have really good observational methods. We're controlling for confounding. We're using the best available statistical techniques. And so to help enhance this part of my personal practice, I completed a master's degree in epidemiology and clinical research with an emphasis on health services research after I started on faculty here. And I found that those tools to be really invaluable in doing quality research. So how do you know if something is research or QI? Do I need to take this to the IRB is one of the most common questions that I get. So the group at CHOP, the IRB really did a nice job of publishing, and so I'm going to share this table with you. But the purpose of human subjects research is to develop generalizable knowledge. And so what I did on this table is I underlined the things that may be really good tip-offs that you are doing something that's more aligned with research versus more aligned with quality improvement, given that there's some overlap in the techniques. For the design of a human research subject's protocol is going to be very rigid. You are more likely to see randomization, where in quality improvement, you're going to see data being collected, but the techniques are adaptive and iterative. In quality improvement, you're going to see the results rapidly adopted into local care delivery. You're really trying to research and optimize something in your own process or your own system, wherein human subjects research, you generally use a longer publication cycle to disseminate your results. And you are obliged to share these more broadly, where with quality improvement, you're encouraged to publish to share the insights from your project, understanding that exactly what you did might not be generalizable to a lot of different settings. That's at the local level. There's obviously some national research to be done as well. So the other concept I wanted to introduce is this learning health systems, which is done by Dr. Mathis and the Multi-Center Perioperative Outcomes Group. This is a really nice paper if you want to learn more about this. But they put up this model of sort of this concept of, on the left, we have data to knowledge through research, and then on the right, we have knowledge to practice through quality improvement, or I'm going to talk a little bit about implementation science in a bit, and how these two aspects of improving clinical care really play off each other, so that we ideally will have this cycle sort of feeding back and forth between the more research-heavy efforts and the more quality improvement and implementation efforts, but that they're not done in isolation, that they're really informing each other. Next, I'd like to talk a little bit about some of the available clinical quality registries. And the concept of having a registry is really to look at patients and outcomes across more than one center. This gives us more power to study rare outcomes, and it also gives us a chance to compare more frequent complications across clinicians, practice settings, and institutions to gain insights about how they might evolve and how we might mitigate them in the future. Some of the considerations, if you're looking at working with a clinical quality registry, whether that's a registry that's established locally within your institution or that shares data across multiple centers, really has to do with what the data is coming in. And I'm sure some of the other panelists today either have spoken or will be speaking about the quality of data. We say, bad data in, bad data out. So administrative data is one form of data that has to do with CPT codes, billing codes. It's generally more accessible, but it's a little harder to draw really detailed insights from. Clinical data is really rich in data points. You might get hundreds or thousands of blood pressure readings from one case, but there are some caveats there about making sure that the quality of the data is good, that you've filtered out the artifact. So we kind of combine these concepts into your access to the data. Are you able to go and self-serve the data? Do you need to have a data programmer to help you wade through it or to remove some of the artifact? How accurate is the data coming to you? And then how usable is it in terms of answering the research or quality improvement question that you have? I'm going to give some examples from the national landscape right now. The ASA has an institution called the Anesthesia Quality Institute that you probably want to know about to enter this field. This is comprised of a couple different projects. One is the Anesthesia Incident Reporting System, where rare events or significant events can be entered sort of on a as they happen basis. So there doesn't necessarily guarantee full capture of all these events, but it can give some interesting data about what's going on in the anesthesia safety world. There's the closed claims database, which a number of large insurers or malpractice insurers across the country have given some data about medical legal cases that were either settled or brought, and they are able to research more severe events like blindness after spinal surgery, or falls from the OR table, or ventilatory impairment after surgery. So some really critical safety questions. There's some data there. But the one I want to spend the most time on today is the National Anesthesia Clinical Outcomes Registry, which is abbreviated NACOR. And this is a data warehouse from the ASA Quality Institute. Not to get too far into the alphabet soup, but the Centers for Medicare and Medicaid Services recognizes NACOR and a number of other registries as qualified clinical data registries through which clinicians and practices can submit some of their pay for performance data. I'll talk a little bit more about that, using this merit-based incentive payment system. So the ASA does have some quality measures. There's some national benchmarking available, and there's a participant user file that's available for research queries. And so you're able to request some. This tends to be more administrative data and more data that has to do with the specific MIPS and ASA quality measures. The next registry I want to introduce you to, and you either have or will have some more detail about this from some of the other panelists, is this multi-center perioperative outcomes group. Again, that's the large construct across a bunch of hospitals with the idea that we can put together clinical data and collaborative academic effort to have good performance improvement in research. And they have a quality improvement arm called Aspire, the Anesthesiology Performance Improvement and Reporting Exchange. This is robust clinical data with validated standard phenotypes. So they've built a construct about what does baseline blood pressure mean? What's the definition of a holiday if you're trying to compare the outcomes on a weekday versus a holiday? They have some of that built in that makes the data more accessible. Easier to answer quality questions. Aspire also has their own set of quality measures and dashboards, as well as topic-based toolkits for quality improvement, and are evolving their subcommittees to include pediatric obstetrics and cardiac. So some exciting work there on the horizon for Aspire. So why do we use quality measures at all? So quality measure is saying, you know, when we look at the care, this action was either done or this outcome was achieved, you know, whatever percent of the time. This can be used to help support best practices. If we establish something, you know, we expect to have, you know, good temperature maintenance, and we're going to be measuring how often that happens, that can help encourage and emphasize that in clinical practice. It also lets us compare individual and group performance to look for either persons that are achieving, you know, really highly, or groups, so we can go to them and say, hey, we noticed you have, you know, really low rate of, you know, reintubation. What kind of things do you have that are supporting that, to generate some ideas about how we can improve quality. We also can measure the effect of interventions on quality, so that we make sure that we're, you know, the checklist or the other cognitive aids we're using are, you know, supporting the quality outcome, and that we don't kind of keep doing things that aren't helpful for quality to the extent that we can measure that. And then there's also pay for performance, which is the idea that some local, regional, or national entities may pay an anesthesia clinician or a group differently depending on how well they perform on some predetermined quality measures. So when we look at a quality measure, it's important locally to consider whether this is meaningful to patients. And so the example we're doing in our group right now is an initiative to promote multimodal analgesia. So is this meaningful to our patients if they end up taking less opioids because we've used other adjuncts? Is that meaningful to our clinicians? Is it meaningful to our system? What's the cost benefit of doing this? And so generally, if you're not sure, you know, where you're headed with quality, you're always looking for better outcomes for a lower cost. Another thing to consider when you look at a quality measure, is it attributable to the anesthesia team actions? In some settings, we want it to be very specifically attributable. In others, we might not care as much if it's only related to the actions of the anesthesia team, if we're taking the quality improvement from the standpoint of just better perioperative care overall. Maybe we're working with our surgeons, with our post-operative care settings, and all of us are working together on the same quality measure. It's always important to consider, is this safe for these, meaning your own subset of patients when you're talking about implementing for quality. And this is also an area for research. You know, is a quality measure that's good for one group of patients also good for another group of patients? And how do we individualize that care to the extent needed? And then when considering quality improvement, you always want to have room for improvement, which is tough. We want to, you know, everybody wants to start with a really high grade on the test, but we actually need to start from a place where we have more opportunity to improve to make our time the best possible use of our time. So just some examples of the quality measures in AQI. There are measures that are endorsed centrally or developed centrally by the MIPS and CMS systems, such as perioperative beta blocker for heart surgery patients. AQI also layers on a few that were developed by the ASA Committee on Performance and Outcomes Measurement that have to do with prolonged intubation, patient reported experience, other topics like that. Aspire also has their own set of quality measures. You can see a whole range of topics here, from acute kidney injury, medication overdose, sustainability, and you can visit their website to learn more about those different measures. I wanted to talk very briefly about implementation science, which has been getting more buzz in the quality improvement, quality research world. This is the study of using moving scientific evidence into widespread practice. So once we know something's the right thing to do, does that mean all of us are doing it? Are we using the intervention? Is one strategy to get people to use the intervention more effective than another strategy? And so these concepts can also be studied in alongside the effectiveness study, you know, to understand both at the same time, to really speed up that time from understanding that something's the right thing to do and doing it full time. And I would direct you to this paper by Dr. Lane Fall for more information on a really exciting emerging field. I'd also like to direct you towards this Squire guidelines. So if you're talking about publishing quality research, I think this is an important thing to be aware of. This is the Standards for QI Reporting Excellence. And it gives some very specific things that reviewers might be looking for in a paper about quality improvement. You can open this up before you even start your project to get an idea of what you might want to define, or how you might be using your time the best. Finally, a brief talk about funding for quality research. There's a number of national organizations that have grants and topic proposals out. The Agency for Healthcare Research and Quality, AHRQ, is a huge national center for funding, and they have some pretty detailed areas of interest that you can browse. The Anesthesia Patient Safety Foundation also sponsors a number of grants, including a mentor training grant that you may be interested in. And then the Patient-Centered Outcomes Research Institute called PCORI is another source for funding, particularly for comparative effectiveness research, so the risks and benefits of 2 different approaches to healthcare. And they also are very interested in underrepresented or historically marginalized populations. So I'm going to close with just a quick review of some of the topics of interest, and you can see I pulled these from the different funding websites and some feedback to show you know, what you might do if you're starting to look for a project in quality research. So looking at data and technology to improve healthcare quality, looking at the design, implementation, dissemination, and spread. So there's your tie-in to implementation science right there with AHRQ, new clinical methods for presenting or the catching early some mishaps related to anesthesia care from the APSF, and the utility of these quality measures and the role of clinician feedback is a topic of interest to the Aspire group. So with that, I'm going to conclude. It was a big whirlwind, and I appreciate your attention. I'm always happy to take questions in the chat. You're also welcome to reach out to me directly. I love quality improvement. I love quality research, and I'm always excited to hear from people who are equally excited. Thank you very much for your time.